Okay, thank you, Dr. Saad. Now I would request Dr. Wakar to please come and give you all a small idea about complications and their management.
I think we've discussed the indications for colonoscopy. The one that we missed in our discussion was iron deficiency anemia, which is very important. Any case of iron deficiency anemia must have a bidirectional endoscopy, which means OGD, duodenal biopsy, and colonoscopy. The rest we've discussed in our discussion. Some of the conditions that we did not mention but are small print are for surveillance purposes. Acromegaly is a high-risk condition for colorectal cancer, ureterosigmoidostomy, and previous bowel cancer. Yeah. So contraindications. Absolute contraindication is whenever there's a withdrawal of consent, you must stop. Endoscopists who are not accredited or competent to perform colonoscopy must not do it. So that is a contraindication. If you've not done it, you bought a new scope and you want to try it out, that's not the way to do it. And if a patient is not cooperative or is in pain, then you should not do it. Either do him under sedation, under GA, or let an experienced colleague do it. Acute severe colitis, as we discussed earlier, toxic dilatation of the colon, one must never do a colonoscopy in that. Acute diverticulitis, again, you don't do it. And acute abdomen, perforated viscous, sometimes the surgeon might want you to do it, but it's a contraindication. The contraindications are usually relative because a lot of the time when you are, it's whether the patient is number one fit for the procedure, whether there are any comorbid factors which would limit the procedure, or whether it's the actual bowel prep that is going to be the limiting factor, or is it the sedation for the procedure. Now, complications, that is important because whenever we do any procedure, there is a risk of complications, irrespective how small the risk is. But you have to quote that, mention the risk of complication to the patient, and if possible, give the patient the statistics for it. So, yeah.
Can I ask, has anybody seen any complications? Has
No.
anybody seen a perfect?
No, they are perfect. They are perfect.
You have? Yes. Polypectomy?
Yes.
Okay.
And what happened to that after, what happened to the patient?
Well, what I saw post-polypectomy bleeding,
No, perforation.
perforation.
I'm asking perforation. You've seen perforation there?
I've seen.
So what did you,
Was big, so we referred the patient for service.
so, fine, sorry, I just wanted to. But diagnostic
can I just
colonoscopy,
ask-
you
yeah.
have not seen perforation.
What was was you doing any therapeutic procedure during that when you had the perforation, or was it diagnostic?
It was polypectomy.
Polypectomy, okay, fine, thank you. Because in diagnostic procedure, it's very rare. We all accept that. I mean, it shouldn't occur. But when it occurs, it's bad because of the mechanism of perforation. Because in a therapeutic procedure, it's more common. I mean, it's well recognized and seen. Because if you are doing a polypectomy, you use a bit of more extra coag current, or there's a weakness in the wall, it will make a burn through. And we'll discuss that when we are discussing diathermy. But in diagnostic colonoscopy, if you get a perforation, then it's a big tear, or you've torn the mesentery of the sigmoid mesocolon or transverse colon, because that is not usually due to a point perforation, it's due to a loop which is caused a perf, and that is really bad, so that shouldn't happen. Most of them occur during either therapeutic procedure like polypectomy or treating a bleeding point when you use too much current, or it can occur in bad diverticular disease. You can go through a diverticulum. Now, factors which are associated with a poor outcome are if the bowel prep is poor, then obviously there's more risk of sepsis, more risk of peritonitis, so that would be more. If the patient has got other comorbid factors, like if the patient is elderly, is infirm, has got heart problems, has got chest problems, then they are more prone to the effects of complications. They are at a higher risk of undergoing surgery. So in those patients, one has to be very careful. If there is delayed recognition of perforation. Now, one of the things, like any other things, you have to be honest at every level. If you suspect the patient is has had a perforation, or if he's complaining of pain which is disproportionate to, the effect of colonoscopy or retained air, then one must do investigations for that. Because you can't just say, well, it's all due to excess retained air, because most of the time the pain can be due to excess retained air. So if the patient is complaining of severe pain, he's peritonitic, then one should investigate with abdominal X-ray or abdominal CT scan, or ask for a surgical opinion better. Because if you've done all that, nobody can fault you. Perforation is a recognized complication, but if you do not take steps to recognize it or to diagnose it, then you are negligent. But if you've done all that you should have done, then you are fine, because anyone can get perforation or complications, right? So, as I mentioned, diagnostic colonoscopy, if you get a perforation, it's usually bad. Bleeding is another important complication of colonoscopy. Sometimes when you carry out a therapeutic procedure, it is apparent immediately. And a lot of the time, whenever I do polypectomy, I always keep my snare there, because when you remove the polyp, don't take your snare out immediately, because sometimes, especially in a pedunculated polyp, the stump might bleed. And if it bleeds and your snare is there, just grab it and don't do anything else. Hold it for some time tight, and it will stop the bleeding, and then you can coagulate it at leisure or put a clip on it. But that keeps your field clear, because if you've taken your snare out and then you are trying to find one and trying to do you might lose your visual field. It all gets covered with blood. So that's one thing. The other thing is, when there is perforation, bleeding, you need to be fully prepared for it. You should have other accessories available to you, like injections of adrenaline. You should have hemoclips there, coag graspers that you can stop the bleeding with it, or have surgical backup. The other important thing to remember is that you might carry out a procedure successfully, everything works fine, the patient goes home, but several days later they can present again with bleeding. And the important thing there is to tell the patient, I do not carry out polypectomies if the patient is going to travel by air within the next 2 weeks. So always tell them that there is a risk of delayed bleeding, so no air travel or long distance travel. Otherwise, you might have a bit of a disaster. So usually it is a relative contraindication if they are traveling. Right. Always do not do things. I always tell people that if you are a featherweight boxer, do not fight with a heavyweight boxer, right? So don't do procedures which you are not fit or were not trained to do. So if you got a polyp which is in a difficult location, difficult access, or behind the fold, or whenever you try to get to it, something the scope flops out, then don't attempt that. Because if it is difficult enough to get, it will be even more difficult when you start getting bleeding there. You can't reach it then. So always let a more experienced colleague do that for you. Secondly, as I mentioned, you should have a full range of equipment available. We mentioned bowel prep very briefly. Bowel prep solutions like the one you use commonly here, phosphate-based, can cause electrolyte imbalances. So if you've got patients with chronic kidney disease or renal failure, you should use them with caution. And in those patients with chronic kidney disease, the preferred option is the polyethylene glycol or PEG type based solutions. Though they are high volume, but they don't cause any electrolyte imbalance. The other caution about phosphate-based bowel preps are that they can cause superficial mucosal erosions or inflammation. So you might see aphthous ulcers because of that. I think, right. Mispathology. Mispathology is an important complication that one should quote during consent process. No matter how good you are, there's still a risk of missing a polyp or a lesion. And this must be quoted to the patient when you are actually consenting them, that there's a risk of bleeding, there's a risk of perforation, and the risk of missing pathology, right? So whenever you've done a colonoscopy, it's all normal. The patient should be told that even after a normal colonoscopy, they should not ignore rectal bleeding, and they should not ignore a subsequent change in bowel habits. Now, how often do these complications occur? People have done, looked at thousands and thousands of cases and come out with the series or statistics of how common the complications are. There is a risk of death in 1 in 5,000 colonoscopies. There is a risk of perforation in about 1 in 1,000 colonoscopies. And there's a risk of bleeding of 1 in 500 colonoscopies. The risk of bleeding is much higher if you are doing a big polyp, right? So if somebody's got a 4 or 5 centimeter polyp with a thick stalk, you should tell the patient that there's a high risk that it can bleed, or I might get a perforation because of this thing, right? If you are doing an EMR, there's a high risk of perforation. It's not 1 in 1,000. It may be 1 in 250, maybe 1 in 50, or 1 in 100. So that depends on the type of thing. Preventing complications. So always choose your patients carefully. If the patient are elderly, they've got higher, other comorbid factors like ischemic heart disease, hypertension, diabetes, the risk of complication is much higher. Risk of complication is fulminant colitis, so don't do colonoscopy in fulminant colitis. We all encourage you to do retroflexion in the rectum, but do not do retroflexion in patients with ulcerative colitis, and do not do retroflexion in patients with post-radiation colitis, proctitis, because you can cause a tear. These are the patients who are at high risk of complication, who has had previous abdominal surgery, especially women who have had hysterectomy are more challenging to do colonoscopies because they've got adhesions. The uterus, has been taken out, the colon flaps back, and it might be tethered back to the tissues there. And risk of anticoagulation. Now, people who are on anticoagulant obviously would have higher, or antiplatelet agent would have higher risk of complication. Now, there are guidelines, the BSG guidelines, the American Society of Gastrointestinal Endoscopy guidelines for patients who are on anticoagulants or antiplatelet agents. Normally, for all practical purposes, whenever I do diagnostic colonoscopy or whenever we do a first index colonoscopy, we do not ask patients to stop their anticoagulants or antiplatelet agents, right? Because they are on the anticoagulants or antiplatelet agent for a reason. They might have severe ischemic heart disease, or they might have transient ischemic attacks, history of transient, or they might have had a stroke. So if you ask them to stop their anticoagulant, or they may have prosthetic heart valves or valvular disease. So if you ask them to stop their anticoagulants or antiplatelet agents, then you are putting them at risk of a heart attack, a stroke, or a seized valve. Now, when you do a colonoscopy or OGD on them, that might be perfectly normal. And if they get a stroke or a heart attack during that time, and it's a normal colonoscopy, you are on very thin ice. You can't defend. Why did you stop that thing? So normally, for all practical purposes, I tell my patients not to stop their anticoagulants, not to stop their antiplatelet agents or aspirin or anything. I do a colonoscopy. If it is normal, if there are no lesions, no polyps to take out, then that's fine. If I'm suspecting a microscopic colitis, I can still take biopsies. There's no contraindication to taking biopsies if the patient is on anticoagulants or antiplatelet agent. You can still do biopsies. What you cannot do is you cannot carry out therapeutic procedures like polypectomies, you cannot do sphincterotomies, you cannot do dilatations. So don't do therapeutic procedures. If you find a polyp or if you find a stricture that needs dilating, then you come out, you inform the patient that you've got a polyp, we need to take that out. So you need to stop your warfarin for 5 days before you do the. Now, if that patient needs anticoagulation, like if he's got a prosthetic mitral heart valve, then you will need to give them low molecular weight heparin during that time, right? We normally give. If the patient is on one of the directly acting anticoagulants like apixaban, the rivaroxaban, the dabigatran, then the standard time to stop the anticoagulant is 2 to 3 days, yeah, depending on which one you are looking at. If the patient is on clopidogrel, yes, then you ask them to stop it for 5 days, right? Okay. In the meantime, you can give them aspirin because aspirin is safe to take during. Yes. So that's what we normally do in. If you are not sure, Uncle Google is always there. You can check the guidelines. Right. Any questions? Because if you don't ask questions, I'll ask you questions. Right. Good. Well, you know everything now. Thank you.